welcome to TryRight. This is Path 365. Myself Srija. So today in this session, you're going to learn about CPT coding guidelines for evaluation and management. So E&M series for CPT coding. So what are E&M codes? So E&M evaluation and management CPT codes, they are used to report cognitive services which are provided by a physician or qualified healthcare professional. So these services focus upon evaluating a patient's condition, managing or deciding how to treat the patient. So you have to think this E&M as a thinking, decision making and planning, which is a part of medicine but not the procedures. So what do these E&M services include? So E&M services, they involve taking history, performing a physical examination, medical decision making and reviewing tests, counseling patients and families, coordinating care. So for example, a doctor evaluating a chest pain and deciding to admit the patient. So a follow-up visit to adjust the diabetes medications. So these are E&M, not procedural codes. So code range for evaluation management is 99,202 to 99,499. So this range includes many categories of E&M services such as office or outpatient visits, hospital inpatient and observation care, emergency department visits, nursing facility services, home visits and preventive medicine services, as well as prolonged services and care management. So not all E&M codes are used the same way. So each category has its own rules. So this slide mentions E&M guidelines which are crucial. So guidelines are instructions on how to select the correct E&M code. So these guidelines, they are found before each E&M category in the CPT code book. So what are the two types of guidelines? So the one is general guidelines which apply to all the E&M services and category specific guidelines which only apply to that section. For example, for only hospital inpatient and observation care. So you have to always read the guidelines first before choosing a code. And category specific instructions. So some E&M categories have special rules. For example, hospital inpatient and observation care. So before the codes are listed, CPT provides who can report the service, how often it can be billed, whether time or MDM is used, and what counts as an encounter. So skipping these instructions can lead to incorrect coding. And key point 5 is documentation purpose. So E&M coding guidelines, they do not establish documentation requirements or standards of the care. So what does this mean? Documentation is not written just to satisfy the coding. Documentation should support the patient care. It should help current and future healthcare terms. And next is face-to-face requirement. So most of the E&M services require a face-to-face encounter with the patient and or family or caregiver. But only the exceptions are 99211 and 99281 codes. So for these codes, face-to-face may be performed by clinical staff, not necessarily the physician. For example, blood pressure checked by nursing staff. So for this, you have to assign the code 99211. So E&M codes, they represent evaluation, decision making and management. So they are used by physicians and qualified healthcare professionals. So these codes, they are organized into categories, each with a unique rule. So guidelines always help you to choose the correct level of services. And these are the main categories of E&M CPT codes. So this shows you where E&M services happen and what type of patient care is provided. So first category is office or other outpatient services. So the code ranges are 99202 to 215. So where it happens in physician office, clinic and outpatient hospital department. So for new patients, you have to assign the code categories 99202 to 205. Whereas in established patients, it's 99211 to 215. So what is coded in these categories? Evaluation, management decisions and follow-up care. For example, new patient visit for hypertension. You have to assign the code 99204. So these category codes, they are the most commonly used E&M codes. So next category is telemedicine services. So only audio, video or audio only based services are assigned here. So patient and provider are in different locations in these categories. So what is included here? Same E&M concepts as office visits. So it must meet the telehealth documentation requirements. For example, video consultation for medication adjustment. So coming to hospital observation services. So here hospital is involved but it is not formally admitted. So what is the purpose of the services? Short-term monitoring to decide discharge and admit as inpatient. So hospital inpatient and observation care services. The code ranges are 99221 to 99239. So where these are taken? So hospital inpatient or observation setting is the place, and it includes the initial hospital care, subsequent hospital care and the discharge services. So CPT now combines inpatient and observation care into this one section. And next is consultations. So consultations takes place in office, hospital and other facilities. So the purpose of consultation is opinion or advice taken which is requested by another provider. So many payers do not recognize the consultation codes often billed as office or inpatient E&M instead. Emergency department services. So this is taken in emergency department pays only and there will be no appointment and the severity varies from minor to life-threatening disease. And there is no new versus established distinction in this criteria. So time is not a factor for E&M emergency department services. So critical care services. So these are generally happen in ICU, ED or hospital. So they are used when patient has life-threatening condition and the provider gives high complexity care. And nursing facility services. So they are taken place in skilled nursing facilities, SNFs as well as nursing home. So they include the initial nursing facility care, subsequent care and discharge management. And coming to domiciliary, rest home or custodial care services. So where this is taken place, group homes, assisted living and boarding homes. For patients who cannot live independently, they do not require hospital care. And home or residence services, they include patient's private home or residence. So the services, they are used when patient is homebound and provider travels to the patient. For example, elderly patient unable to visit the clinic. And coming to prolonged services. So these are generally used when E&M service goes significantly beyond the typical time. So what will be the common results here? It may be an extensive chart review, complex counseling or care coordination. For example, extra 45 minutes reviewing the records for complex case. And coming to case management services. So generally these case management services focus on coordinating the care among providers, multidisciplinary discussions, example like team meeting for complex oncology patient, and care plan oversight services. The code ranges are 99374 to 99380. So these are used for ongoing supervision of home health care and hospice care. So example like reviewing the reports, adjusting the plans without face-to-face visit. And next is preventive medicine services. So what is the purpose of preventive medicine services? To prevent the illness before symptoms occur. So they generally include routine physical exams, health screenings, immunization counseling and risk factor reduction. So who is involved here? Children, adolescents and adults, new and established patients. For example, annual physical exam. And non-face-to-face services 99421 to 99458 code series. So in this, there is no in-person visit required. It includes online digital E&M services, telephone services, and remote evaluation of images or videos. Special evaluation and management services. So these are generally used for non-traditional evaluations such as medical exams for insurance, employment, legal purposes, and disability determinations. Example, independent medical examination. So these services, they are often not related to directly treatment. And newborn care services. So who are involved here? Newborns, healthy newborns, where in the hospital or birthing center. So this generally they include initial newborn exam, daily care of the newborn and discharge care of the newborn. Delivery or birthing room attendance and resuscitation services. So the code ranges are 99,464 to 99,465. So these are generally used when provider is present at delivery, neonatal resuscitation is required. For example, pediatrician call to delivery due to fetal distress. So you have to report only when attendance or resuscitation actually occurs. And neonatal and pediatric critical care. So generally this is for critically ill neonates and children which taken place in NICU or PICU. This is a time-based service and these are age-specific as well as severity-based services. Cognitive assessment and care plan services. So generally, cognitive assessment services, they are used for cognitive impairment, for example, like dementia. So they include the detailed cognitive assessment, function evaluation, and creation of a care plan. For example, Alzheimer's disease evaluation. And coming to care management services, they focus on chronic condition management and care coordination over time. So they include both chronic care management as well as principal care management. So they are often billed monthly. So psychiatric collaborative care management services. The code ranges are 99492 to 494. So this is a team-based mental health care. It involves primary care provider, behavioral health specialist, and care manager. So example is depression managed collaboratively in primary care. So transitional care management services, generally these are used after the hospital discharge, SNF discharge. It includes follow-up within 7 days and 14 days. So it combines face-to-face services plus non-face-to-face works. And coming to advanced care planning, it is used for end-of-life discussions and also advanced directives. For example, discussing DNR or living will. So in this, the patient consent must be documented clearly. And next category is general behavioral health interpretation care management. The code is 99,484. So this is for general behavioral health care within the primary care. Example like anxiety management integrated into a routine care. And other E&M services, example, these are used when no specific CPT code exists. So the code ranges are 99,459 and 499. So these are the categories of E&M coding in CPT. So next is classification of E&M services. So the E&M section is divided into major categories based on where and how care is provided. So the common categories include office or outpatient services visits, hospital inpatient care, observation care, consultations, and emergency department services. So the location and the type of encounter determine the category first but not the diagnosis. So what are the subcategories within each category? So most E&M categories are divided further. For examples, office visits, new patient and established patient, in hospital inpatient or observation care, as initial care and subsequent care. So example like first time seeing a patient in clinic, it comes under new patient, and daily hospital progress note, it's a subsequent inpatient care. So there are levels of E&M services. So each subcategory is divided into levels of service represented by specific CPT codes. So these levels, they reflect complexity of medical decision making or the total time spent on date of the encounter. For example, office established patient visit. So for low complexity, you have to assign 99212 code. For high complexity, you have to assign 99215. So higher the code, the higher the work will be and the responsibility more, not just longer notes. And what is the basis for code selection? For MDM or time. So levels of E&M services are selected based upon the MDM or time. So medical decision making includes the number and complexity of the problems, amount or complexity of the data review, the risk of the complications or management. And the time includes the total time spent by the provider on the date of the service and face-to-face plus non-face-to-face work. So you have to choose either MDM or time, but not both. And what is the standard format of E&M code description? So every E&M code, CPT code, it follows a predictable structure which it is broken into 4 parts. So first, the code number. For example, 99214, it identifies a specific level of service. Second, the place and type of the service, whether it's an office or outpatient visit, hospital, inpatient care, or emergency department visit. Third, the content of the service. It describes the nature of the evaluation, management responsibility, and the clinical work expected. And coming to fourth, it is a time. So typical or total time associated with the service. It is used when selecting level by time. So time is always listed last in the code description. So place of service and service type. So the core rule is the place of service is determined by where the face-to-face encounter occurs, not where the patient usually lives. So, for example, a nursing facility resident brought to a physician office. So, you have to report office or other outpatient E&M code. So, patient residence does not decide the code, encounter location it decides the code. And new and established patients. So, what is the difference between new and established patients? So, how do you define it? So the classification is used only for E&M coding purposes. So which services count for determining new versus established? So only face-to-face professional services count. Physical services, qualified healthcare professional services, lab tests, x-rays or procedures alone, they do not count the new versus established patient services. So what is the definition of the new patient? So a new patient is one who has not received any professional services from the same physician or qualified healthcare professional, or another physician or qualified healthcare professional of the same specialty and subspecialty in the same group practice within the past 3 years. For example, patient last seen 4 years ago. He is considered as a new patient. Patient saw same specialty last year. He is considered as an established patient. Now, what is the definition of an established patient? An established patient is one who has received professional services from the same specialty or subspecialty within the same group practice within the past 3 years. For example, follow-up visit 6 months later. So, he is considered as an established patient. So, what is the critical rule here? For specialty and group practice. So, same specialty plus subspecialty plus same group considered as established. Different specialty even in the same group considered as a new patient. So, example, patient saw a cardiologist last year. Now sees a pulmonologist in the same hospital. So, still he is considered as a new patient. And what is advanced practice providers? Who are those? So, when nurse practitioners, NPs, or physician assistants PAs work with the physicians, they are considered the same specialty and subspecialty as the physician. For example, patient saw physician assistant in the cardiology last year. So now he sees the cardiologist in the same group. So this is considered as an established patient. So advanced practice providers visits do count towards the 3-year rule. So emergency department visits, no new versus establishment. So there is no distinction between new and established patients in the emergency department. So what does this mean? So emergency department E&M codes 99,281 to 288, they apply to any patient. So it does not matter if the patient has been seen before, the patient is new to the hospital, or the patient saw the same doctor last week. So everyone in the emergency department is treated the same for E&M coding. So why this rule exists? Because ED care, it's episodic and unscheduled. So providers must treat based upon the urgency but not the patient history. For example, patient visited the emergency department 2 days ago. So still he is reported as ED E&M code. So patient seen by the same ED physician earlier. So it is still coded as emergency department E&M code. So what is a decision tree for new versus established patients? So the CPT provides a decision tree to help to decide new patient versus established patient E&M codes. So this applies to office visits, outpatient visits, but not emergency department services. So if the setting is emergency department, you have to stop thinking about new versus established patients. So next is initial and subsequent services guidelines. So this concept applies mainly to hospital inpatient care, observation care and nursing facility care. So what do initial and subsequent mean? So the initial service is a service which is provided, which is a first face-to-face professional E&M services provided by a physician or qualified health professional of the same specialty and subspecialty within the same group practice. So during a single admission or a stay. For example, first hospital admission note, it considered as initial inpatient care. First observation visit, it is considered as initial observation care. So coming to subsequent services, a subsequent service is any follow-up E&M visit after the initial service during the same admission or stay. For example, daily hospital progress notes. and follow-up nursing facility visits. So important clarification is face-to-face rule still applies here. So only face-to-face professional services count when deciding initial versus subsequent, but not the labs, imaging or procedures alone. Coming to same specialty and same group rule. So same specialty plus same group considered as subsequent encounter. Different specialty, it may still report as the initial service. So what is a subsequent service? It occurs when the patient has already received the professional services from the same physician or another physician or of the exact same specialty and subspecialty within the same group practice. So it may occur during the same admission and stay. So if someone from the same specialty plus same group has already seen the patient during that stay, all future visits are subsequent. So for example, hospitalist admits the patient. So it is considered as the initial inpatient care. So some hospitalist sees the patient next day. So it is considered as subsequent inpatient care. So another hospitalist from the same group sees patient. So it is still subsequent. So now what is the role of NPs and PAs here? So what is the role of the advanced practice providers? So when NPs and PAs work with the physicians, they are considered the same specialty and subspecialty as a supervising physician. So why this matters? If an NP sees the patient first, so the physician visit later is subsequent. If physician sees the patient first, NP visit later is subsequent. So example, day 1, the hospitalist team, NP, admits the patient. It is considered as the initial inpatient service. Whereas day 2, the physician from same group sees the patient. It is considered as a subsequent inpatient service. So advanced practice providers do not create a new specialty for E&M coding. And then observation is inpatient, one single stay. So for hospital coding, a stay that starts as an observation and later converts to inpatient is considered one continuous stay. So this prevents the double initial billing. For example, day 1, patient is placed in observation care, which is considered as initial observation, and day 2, status changed to inpatient. So you do not reset to a new initial inpatient service now. So next is the nursing facility services. Same stay rule. So for nursing facility services, the transitions between skilled nursing facility and nursing facility level of care are considered as the same stay. So what does it mean? You do not bill a new initial service just because the level of care changes here. Our next guideline is regarding split or shared visits. So what is a split or shared visit? So when a physician and a qualified healthcare professional both participate in a single E&M encounter on the same date for the same patient. So who can bill the visit? So the provider who performs a substantive portion of the visit may report the service. So substantive portion usually means medical decision making or the majority of the total time. So exact rule depends upon the current CPT or Medicare guidelines. So the example is NP gathers history and exam. Physician performs the MDM and final plan. Now here, physician may bill the E&M. Whereas, physician does brief check, NP performs MDM and most of the work. So in this scenario, you have to code for NP. So in this, the NP may bill the E&M. So this is a split or shared visits. So there is a time-based code selection in the split or shared visits. So if code selection is based upon the total time on the date of the encounter, the E&M service is reported by the professional who spent the majority of the time, whether face-to-face time or non-face-to-face time. So when time is a deciding factor, whoever spends more than 50% of the total E&M time bills the visit. Example, NP spends 25 minutes, physician spends 15 minutes. So total time is 40 minutes. So here more than 50% of the total time is billed by the NP because he has consulted the patient majority of the time. So you do not add times together and bill twice. So one visit is for one code. So substantive portion of MDM, what is it? So to count as performing a substantive portion of MDM, the physician or qualified healthcare professional must make or approve the management plan. He must take responsibility for the number and complexity of the problems, risk of the complications, morbidity or mortality. So simply reviewing the notes or co-signing is not enough here. For example, NP gathers history and exam. So the physician determines the diagnosis, orders the high-risk medication and approves the treatment plan. So physician performs substantive MDM. In this, a physician may bill. So physician made the management decisions here. And what are the levels of E&M services? So two ways to select an E&M level. You choose one of the following, either the MDM, medical decision making, or total time on the date of the service. So you should not combine MDM and time. So what are the number of levels available here? So within each MDM, within each E&M category, they are office, inpatient, ED, etc. So there are 3 to 5 levels of E&M services. So each level has specific definitions. For example, in office visits, the patient type is new patient, the levels are 5 levels. So in patient type established patient, the levels are 4 levels. So levels are not interchangeable here. So E&M levels do not mean the same time across the categories. A level 3 is not universal. So example, the office visit, new patient has level 1. The office visit, established patient has level 1. So they have different MDM requirements, different time ranges and different CPT codes. So levels only make sense within their own category. And what are the guidelines for selecting level of services based upon the medical decision making? So first of all, what is MDM? What is medical decision making? It reflects how complex the patient's problems are, how much data the provider must review or analyze, how much risk is involved in the management. So there are 4 levels of MDM. So CPT recognizes 4 MDM levels: straightforward, low, moderate and high. So higher the MDM, higher will be the E&M level codes. So MDM level does not apply to CPT code 99211 or 99281. So these are minimal services with no defined MDM. So what makes up MDM? The 3 elements. What are those? Element number 1, number and complexity of the problems addressed. So this includes the number of problems, whether they are self-limited, acute, chronic, stable versus worsening or life-threatening. So only problems addressed count, not just listed. And element 2, amount and or complexity of the data to be reviewed and analyzed. So this data, it includes medical records, lab tests, imaging, external notes, and history from the family or caregiver, independent interpretation of the test, interprofessional discussions, which are not separately billed. So ordering a test counts, reviewing the result counts, and interpretation also counts. So the review of test results is considered a part of a same encounter but not a new visit. And element 3, risk of the complications and or morbidity or mortality. So what it is? So risk is based upon the diagnostic procedures, management options, medications, surgical decisions, patient comorbidities. Risk can be minimal, low, moderate and high. So how to determine the MDM level? It's a golden rule. So 2 out of these 3 elements must meet or exceed the same level. So ordering versus not ordering a test. So what is the important clarification here? So ordering a test is included in MDM. Reviewing the rest is included in MDM. So if a test is not ordered due to a patient risk, it still counts. For example, CT scan normally ordered and it is not done due to pregnancy or renal failure. So it still contributes to the MDM complexity. And for example, straightforward MDM, which has single minor problem, there are no tests or minimal data performed, and it's a minimal risk. Coming to low MDM, there is an acute uncomplicated illness, simple laboratory tests are performed, and OTC medication. And moderate MDM, there are multiple chronic conditions seen, and prescription drug management is given, imaging ordered, and there is a moderate risk. Coming to high MDM, they are acute or chronic illnesses with threat to life. So it is life-threatening condition, and also extensive data review is performed, and there is a high-risk medication or a surgery decision. And MDM data and documentation. So what documentation is required? So data are divided into 3 categories. So what are those? Number 1, documentation is mandatory. So this MDM only counts if it is documented. So if it's not written, it's not counted, even if it was done. And second is data element of MDM. So three categories. So the data component of MDM is divided into three categories. Higher the data complexity, higher the MDM level. So what is the category 1? Test documents, orders, or independent historians. So this includes lab test ordered or reviewed, imaging studies ordered or reviewed, medical records reviewed, notes from other providers, history obtained from their family member, caregiver, E&M, EMS, nursing staff, and important rule here is each unit test, order, or document counts separately. So independent historian is especially important when patient is confused, pediatric patients, dementia patients, and language barriers happening. So category 2, independent interpretation of the test. So this applies when the provider personally interprets a test. The interpretation is not separately reported. Example like reading an X-ray yourself, reviewing an ECG tracing, and reviewing the CD images independently. So does not count if a separate CPT code for interpretation or report is billed. So you can either bill for interpretation or you can count it towards MDM but not the both. And category 3, discussion with external physician or qualified healthcare professional. So generally, this includes the phone calls, secure messaging, in-person discussion with the external physician, specialist, another qualified healthcare professional, appropriate non-physician source. So only counts if the provider documents the discussion. It is not separately reported. And what is a shared decision making? So what does it mean? Shared decision making involves discussing the options, explaining the risk and benefits, considering the patient or family preferences, and also the patient education. So examples involve choosing surgery versus medical management, deciding whether to admit or discharge, selecting among the treatment options. So shared decision making, it supports higher MDM, especially under risk. And what is the role and management responsibility? So MDM credit depends upon who is responsible for care. So if a physician or QHP, qualified healthcare professional, bills a separate CPT code for interpretation or report. So that interpretation, it cannot be counted towards MDM. For example, radiologist bills for CT interpretation. In this, ED physician cannot count the CT interpretation towards the MDM. So to qualify for a specific MDM level, two of these three elements must be met or exceeded. So the three elements are the problems, data, risk. So even if one element is high, you still need two. And this is for today's session. I hope the session has helped you. So the next session, you are going to learn the continuation of Evaluation and Management Coding Guidelines in the CPT section. Thank you.